Hey everyone. So, in the clinical microlab, we all have those organisms that are just true enigmas, right? Well, today we're going to tackle one of them, Moraxella non-liquefaciens. Now, everything we're about to cover comes from a Gemini deep search into the latest research. And for all of you who really want to dig in, the full citation notebook is available. So, let's get into it.
This quote really just hits the nail on the head. Moraxella non-liquefaciens isn't just another name on a list of bacteria. It is the textbook example of an opportunist. It's perfectly happy just hanging out in the respiratory tract of healthy people, causing no trouble at all. But you give it an opening, say a compromised immune system or a medical device, and it can flip a switch and become a really serious pathogen. So let's get one thing straight right away. This is not some new superbug that just appeared out of nowhere. The organism itself hasn't really changed, but our labs have. It's emerging for one simple reason. Our technology has finally caught up to it. For years, it was probably written off as a contaminant or just plain misidentified. But now, with tools like mass spectroscopy, we can put a name to it, and that's revealing just how often it was there all along. Okay, so here's our game plan for today. First, we're going to get to know the organism itself. Then we'll dive into why it's such a headache for traditional lab methods. After that, we'll see how modern diagnostics finally cracked the case, what diseases it actually causes, and then, and this is the important part, we'll translate all of that into effective antimicrobial strategies and prevention. It's the whole journey, right, from the lab bench to the patient's bedside.
So, who is this organism really? Let's start at the beginning with its formal identity and its playbook for causing disease. All right, taxonomically, it's in the Moraxellaceae family, so it's a cousin to bugs we know well, like Acinetobacter. But the really critical detail in this slide is that historical note. Before 1967, it was constantly confused with what we now call Moraxella osloensis. And that's a huge deal. It means if you're digging through any of the older literature, you have to be super careful because that case report you're reading might not even be about the right bub. So how does it make that leap from harmless resident to nasty pathogen? Well, it follows that classic two-hit model. Hit number one is host vulnerability. Think of a patient with neutropenia or maybe an indwelling catheter. That's the opening it needs. Then comes hit number two, the bacterium's secret weapon, which is biofilm formation. It can create this sticky, protective shield on surfaces like catheters, letting it hide from the immune system and fend off antibiotics. It makes these infections incredibly tough to get rid of.
Okay, now let's head over to the lab bench, because this is where the real drama begins, and it's the reason this organism flew under the radar for decades. On paper, it's a gram-negative coccobacillus. Simple enough, right? But in practice, oh, it can be an absolute nightmare. The gram stain is often variable, meaning it can hold onto the crystal violet and look gram-positive. So right away, you might be heading down the completely wrong path, thinking you've got something like a bacillus. And the colony morphology doesn't help either. Sometimes it's mucoid, other times it spreads out and literally pits the agar. It's a true masquerader. And this slide just perfectly illustrates the problem. If you start digging through different textbooks and papers, you will find completely contradictory information about whether it grows on McConkey agar. Some say yes, some say no. And look, that's not some minor detail. That's a critical step in a lot of traditional ID algorithms. This one variable pretty much makes conventional biochemical panels and flowcharts totally unreliable. So that really leads us to the central question for the lab, doesn't it? If the gram stain can fool you and the basic culture characteristics are all over the place, how in the world can we get to a definitive, confident, species-level identification? Well, the answer lies in technology that stops looking at what the bacterium does and instead focuses on what it is. Enter MALDI-TOF mass spec. This technology has been an absolute game changer for biochemically lazy or tricky organisms, just like this one. Instead of relying on fickle biochemical reactions, MALDI analyzes the organism's unique protein fingerprint. It just cuts right through all that phenotypic noise and gives you a rock-solid species ID in minutes. This right here, this is the single biggest reason Moraxella non-liquefaciens is finally on our clinical radar. But what if you need absolute 100% certainty? Well, for that, 16S rRNA gene sequencing is the final word. It's definitely slower and more expensive than MALDI-TOF, but it is the ultimate gold standard. It's what you use to confirm a really critical isolate, to sort out a confusing MALDI result, or for things like an outbreak investigation. Okay, so our labs can now confidently find this thing. The next big question is, what are we finding? What kinds of diseases does Moraxella non-liquefaciens actually cause in people?
Well, the clinical picture we're seeing totally confirms its identity as an opportunist. Look at the list. It causes severe eye infections, but usually after surgery. It can cause sepsis, but almost always in patients who are immunocompromised. It can even cause meningitis, but that's typically when there's a cranial defect, giving it an easy way in. And pneumonia, again, usually in patients who already have chronic lung disease. The pattern is crystal clear. It exploits weakness. Now, this next section, this is probably the most important one for us working in the lab. How do we test it? And maybe more importantly, how do we report the results in a way that actually helps guide therapy effectively?
Let's start with its resistance profile. First off, it's intrinsically resistant to drugs that target gram-positives, like vancomycin, so don't even bother testing them. The big thing you have to watch out for is beta-lactamase production. Just like its famous relative Moraxella catarrhalis, it loves to produce enzymes that chew up simple penicillins. What that means clinically is that amoxicillin is probably off the table. Now, while it's often susceptible to broader drugs, you absolutely have to perform susceptibility testing every single time.
And here is the major challenge. There are no official EU-CAST or CLSI breakpoints specifically for Moraxella non-liquefaciens. This is where our job shifts from just running tests to being true clinical consultants. The accepted strategy is to use what are called surrogate breakpoints. In this case, we borrow the established breakpoints from its close relative, Moraxella catarrhalis, to help us interpret our results. So this table right here, this becomes our guide. We figure out the MIC for our isolate, and then we compare it to these surrogate breakpoints. So, for example, if you get an MIC of 0.5 for ceftriaxone, you'd interpret that as susceptible. But, and this is the crucial step, you don't just put an S or an R on the report. You have to report the actual MIC value and add a comment explaining that the interpretation is based on surrogate data. This gives the clinician the full context they need to make the best decision. And that guidance is absolutely critical for treatment. Now, while the Dutch swab guidelines don't mention this organism by name, the approach is clear. You treat the clinical syndrome empirically, say febrile neutropenia, and then you use the AST results we provide to de-escalate to a more targeted therapy. Internationally, drugs like piptazo or ceftriaxone are pretty common choices. For kids, of course, everything is dosed by weight, but the single most important message for every single patient is that source control is king. You have to get that infected catheter out. You have to repair the defect. Antibiotics alone will often fail if you don't. Okay, finally, let's talk about how we can prevent these infections from even starting, especially when we're talking about our most vulnerable patients. There are no specific magical guidelines just for Moraxella non-liquefaciens, so we fall back on the core principles for preventing all healthcare-associated infections. Look, this isn't rocket science, but it does require constant vigilance. It all starts with meticulous hand hygiene. It includes using standard precautions for every patient and using strict aseptic technique for any invasive procedure, and it also extends to the hospital environment. Thorough disinfection and smart management of water systems, which can be reservoirs for all sorts of gram-negatives. So when you step back, the story of Moraxella non-liquefaciens is really the story of modern microbiology. It's such a powerful reminder that our diagnostic technology literally defines our understanding of epidemiology. What we can identify, we can track. And for those of us in the lab, it really highlights how our role is changing. It's not enough anymore to just produce a result. We have to be active consultants, helping clinicians navigate the nuances of these rare organisms to make sure our patients get the best possible care. And that wraps up our deep dive today. If you found this helpful, please subscribe for more explainers just like this one, designed for the clinical lab. And honestly, I really want to hear from you. If you've ever dealt with a case of Moraxella non-liquefaciens, please share your experience in the comments. We all get better when we learn from each other. Thanks so much for watching.